Hello friends, and welcome back to my channel. If you are new here, my name is Julia and I am a fourth year medical student, soon to be graduating and becoming a first year medical resident, you guys. I have really enjoyed this Rotate With Me medical vlog video series, you guys, and bringing you along with me during my medical school rotations and giving you a little bit of insight into what the life of a medical student is truly like as we learn all that we can and really build the foundations of becoming a good doctor. So for my final medical school rotation, I want to introduce you guys to the field of emergency medicine. Emergency medicine is the medical specialty that deals with the care of patients with acute illnesses and injuries that need immediate medical attention. Emergency medicine doctors are truly the first line of defense at the hospital, you guys. The true frontline healthcare workers, right? All patients come through the emergency room doors and are triaged and sorted and assessed to see, are they sick or not sick? And then what's going on with them so that we can sort them to the part of the hospital that they need to be at, right? Is it a heart issue? Are they having a heart attack and thus need to go to cardiology, right? Are they having stomach pains or something wrong with their bowels and they need to go to GI? Are they having a surgical emergency? Are they in trauma, have an open wound and need something fixed that surgery requires, in which case they need to consult surgery and go to the OR, right? Get operated on. So emergency medicine doctors are the true masters of kind of assessing and evaluating and sorting patients to the appropriate place of the hospital where they can get the further care that they need. Because they see a mix of everything, right? They're really a jack of all trades in that they have to be able to quickly assess and evaluate a patient and come up with a likely diagnosis of what's going on so that they can be further sorted appropriately, or so that they can call and consult the proper specialists or specialized doctors that deal with the most likely diagnosis of what they think is going on. Because they need to have this kind of diagnosis in mind of what they think is going on, they have to do a full workup usually in the ED to really narrow down what's happening and get the lab results, the proper imaging, so that when they consult the doctors that are specialized in what they think is going on, they have the data, they have the kind of evidence to back it up to say, hey, I got these labs, I got this imaging, and this confirms what I think is going on, which is why I'm consulting you, because this deals with something you deal with, you know what I mean? So we've done the initial preliminary workup in the emergency room, and now here you go, this patient belongs to you. It is a very fast-paced environment in the ED, especially in large academic medical centers, level 1 trauma centers, where you're seeing very significant, illnesses and diseases and injuries, especially at trauma centers, that you have to be very quick-paced in this environment. You have to be composed under pressure, and you have to be able to kind of triage and assess and prioritize your patients and your responsibilities. It's amazing to watch emergency medicine doctors do what they do in their environment. I've been on this rotation for about a week now, and I am amazed at just their level of composure and calmness in such high intensity, high stakes environments, and I'm just amazed by it. So in this rotation, I'm gonna show you guys a little bit about my time thus far over the last week in the emergency room, and hopefully we get to see some cool patients. So let's go. New rotation alert. I am beginning my emergency medicine rotation. So I had orientation this morning, and I'm going to be in EM for 4 weeks, rotating through the emergency department, like the main emergency department. I'm going to be in fast track, which is kind of like an urgent care type of setting, less severe, less urgent type of issues that don't require being in the main emergency room, but you can kind of get in and get out fast, right? No pun intended. So fast track is also a part of emergency medicine, as well as pediatric emergency medicine. So different parts of EM that I'm going to see over the next 4 weeks, and today begins my first day. So I'm coming in from the 3 to 11 shift, and I'm going to be in fast track. So let's get the day started. I'm so excited, you guys. 4 weeks, last rotation of med school. Hopefully we get to see a lot of cool stuff. So let's get it going. So I'm on lunch. It is 6:15 at night. So I'm, 3 hours and 15 minutes into the shift, but it's also getting late at night. That's like the weird thing about working like the mid shift, the 3 to 11, is that everything just is kind of pushed back, but you're taking a lunch earlier than midway through the shift and whatever. But anyway, I packed my own lunch because I'm trying to be healthy, you guys. So I have this little chicken wrap, this little chicken basil pesto wrap that I made, and a yogurt and some water. I'm gonna eat my lunch, grab a cup of coffee, and then go back up to the fast track ED. So as I was saying earlier, you guys, the fast track is really for like non-emergent kind of things, like things that don't really require being in the main ED, but more so like an urgent care kind of setting, right? So we're seeing people with stomach aches and people who just need like a CAT scan or an x-ray, like that have fractures or something like that. Things that can kind of get wrapped up in a bow and sent out the door quickly. So I actually had a patient today, you guys, that needed a rectal exam, and I was like, I have these nails on. Like, so as you guys can see, I chewed this sucker off real quick because I did not want to put these into someone's anus. Like, what? I didn't know I was going to be working this shift today, so I didn't have time to take my acrylics off, which I plan to do tomorrow. So yeah, I had to chew this one off so that I can do a rectal exam. Luckily for the patient, I didn't do the rectal exam. My attending doctor did, but still I started freaking out once he said, oh yeah, we're going to go back in and do a rectal exam. I'm like, oh, I would be livid if someone did that to me. So yeah, chewed it off real quick. But anyway, I'm gonna eat my lunch, you guys, go back up to fast track, try to stay busy for the rest of the night. Fast track is actually pretty slow moving, ironically enough. A lot of stuff is just waiting on tests or waiting on IVs, medications, things like that, and waiting for the room to kind of turn over to put another patient in there. But it's whatever. All right, guys, so I just got home. It is 9 o'clock on the dot, 9 p.m. So I got let out early. We love doctors who let us out early, you guys. Like, whoo! And you get to the point, you know, in your third year when you first start rotations, you're like, oh no, like I'll stick around, you know, like it's all about your impression and your evaluations and stuff like that. When fourth year comes, you guys, and you're like literally done with all you need to graduate, and the rotations and the evaluations and all those things don't matter as much, it's like, oh, you're dismissing me? Okay, see you later, bye. And you're out the door before they can even say have a good night, you know? It's like, psh, I'm gone. So anyway, so I saw in total myself, I think 3 or 4 patients. I saw another like 2 or 3 with the doctor. I didn't see them exclusively by myself. I didn't have to write any notes, which is great, you know, because the doctor was like, you know, I have to put in a note anyway, so why should we both do the work? Like, so what the doctor instead did was, as I gave the verbal presentation, so 28-year-old female, no past medical history, coming in with nausea and vomiting for 1 week, she says that, yada, 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 right? As I was giving that verbal presentation, he was writing the note, right? So he was kind of scribing the note based on my verbal presentation, right? And then we would go in together and see the patient. And then that's when he would finish the note, make sure all the labs, tests that we wanted are ordered, all that stuff. So it was a very good like dynamic. I like when attendings give you that autonomy and that space to really go see the patient first, present, give your assessment, right? Like, what do you think is going on? Okay, what do you want to do for that? What's the common tests or labs or whatever? And really make you think about it, right? Because I believe, at least for me personally, and probably a lot of other medical students, is the transition between your knowledge in the book stuff, right? Like the book smarts to the clinical smarts is the difficulty, right? Like using all the knowledge that you have, all the stuff they made you learn about in med school, and translating that to how you use that information to inform your clinical diagnosis and treatment and stuff is really the hurdle, and that is what you get really good at in the last year of medical school, or in, you know, residency in particular, right? So I feel like doctors who give you that space to think through those things without putting on that pressure and that like, oh, you're stupid type of stuff, is like, those are the doctors that really make great doctors after them, right? So he had me thinking through things, and we talked through like, what's your differential diagnosis, why, you know, what's more common than this, and that really helps a medical student really elevate their game and their clinical knowledge, right? Because the book stuff, I argue, is not as important, right? Like, what good is it to know all the causes of freaking anemia or thrombocytopenia or whatever if you don't know what to do with that information and how it presents and informs your clinical diagnosis and treatment. So anyway, you know, I always thought that I would be the type of person to really be interested and potentially go into emergency medicine. What I found, you guys, is that when I was on my other rotations and I'd have to go down to the emergency room to, like, you know, see a consultation. So if I was on cardiology and we had a patient in the emergency room that had some chest pain or whatever, and we'd have to go down to the emergency room to see them, I was overstimulated, you guys. Like, the emergency room is a wild place, like a super wild place, probably the wildest in the hospital. So much going on, craziness, whatever. And I feel like in order to work in the emergency department, you really have to be desensitized to it, right? Like, you can't overreact or lose your focus when someone's screaming over there, or when people are yelling at nurses over there, or when someone's shouting and throwing stuff and vomiting, and there's just a lot going on. And me, the type of person I am, I'm like, what's that? What's that? I'm like nosy, but also like I want to help people. So that's a recipe for disaster in the emergency room, okay? Right? Because I'm gonna be like, ooh, what they talking about? What they fighting about over there? You know, like, oh, he's getting restrained. Like, oh, she's shouting. Like, you know, and then it's like, but I also want to help. Like, everybody's calling you, right? Ma'am, excuse me, doctor, miss, can you get me this? Can you? And it's like, I want to help, but I can't do that for all of y'all. So the emergency room for me was just overstimulation times 100, and I wasn't able to focus down there. And when I was on pediatrics, I had to do a stint in the pediatric ED, and I just never really felt super comfortable in the ED. And like, it was a great place to pass the time quickly. There's so much going on that the time passes. You also get to do a lot and see a lot, and I like that aspect of it. But essentially it just came down to like, it's a little too fast paced for me, which is ironic because I love the fast pacedness of medicine, but it was just like, it was too much for me. So I'm glad that I'm gonna get this 4 weeks to do it, just because it is something I think I enjoy. It's just not something I wanna do long term. So these next 4 weeks, I think I'll get my fill. So I'm really excited. Like today, I had patients with all different types of stuff going on, you guys. I had a patient who was coming in with nausea and vomiting, and she ended up being pregnant. I had a guy who fell and busted his head, and both of his eyes were like fractured. I had a guy who got an STD. I had a guy that got in a motor vehicle accident and had his leg splinted. So just so much different stuff you get to see, and it's really, really cool in emergency medicine to kind of just like see it all, get them in, get them out, and move on to the next. Good morning, friends. So we are back for emergency medicine shift number 2. Yesterday I had off. You guys can see I took all of my nails off. I'm prepared today, and today I'm back for the morning shift, so I'll be working 7 a.m. to 3 p.m. Today I will also be back in fast track, so the same part of the emergency room that I was in for my first shift, I'm back there except for a day shift rather than an evening shift. So very interested to see how fast track changes from the morning versus the evening, you know, especially being that fast track is less urgent, less emergent type of problems, right? So I'm always thinking, would people rather sit in the hospital all day in the morning or the evening? So I guess I will find the answer to that today. I woke up early, I made myself some breakfast, I have my coffee here. You guys, the sun isn't even up yet, and I don't remember the last time I was up before the sun for something academic or school related. As you guys may have known, I've been on vacation for the last like month because in your 4th year of medical school, you have so much vacation time. The 4th year of medical school is actually a waste of time if we're being completely honest, but I had so much vacation time, so I took trips to Jamaica and Portugal, and I was just living my best life, you guys. So now it's like that weird adjustment of getting back into the swing of like school and like seeing patients and preparing for a freaking shelf exam. So we will get through. Okay, so let's go see what this day is looking like. I hope we see some good stuff, and I will check back in with you guys in a bit. All right, you guys, so I am done for the day. It is 2:30. My attending let me go a little bit early, and overall I just had an amazing day, you guys. So I say in these Rotate With Me vlogs, and I've said many times before, that your team, the team that you're working with in medicine, really makes or breaks your experience, especially on like rotations in medical school or nursing school or PA school or whatever. Like, you only spend a fraction of your time with the patients themselves, right? The majority of your time is spent with the other members of the healthcare team. So those individuals inherently like make up a large point of like your perspective and your outlook on the rotation that you're on. And that's why sometimes people find that they don't like certain specialties, not because they didn't like the medicine that they saw in that specialty, but rather they just have a skewed, jaded perspective because of the individuals they were working with, right? So all of that to say, be aware of that and learn to kind of weed through what you like or don't like about a rotation and what is contributing to that perspective. So all of that to say, I had an amazing day, mostly because of the attending I was working with. He was super cool, you guys. Like, we didn't have that many patients, first and foremost. I only saw about like 2 or 3 patients. One had swelling of the penis, actually, like, Lord knows. I had another patient who has diabetes and is literally getting all of his toes amputated. They're ulcered and like he can't feel them, and it's just really bad. And I had one other patient who had a motor vehicle accident this morning at like 1 a.m. and he was coming in with like some residual neck pain and back pain. So we just gave him Tylenol because nothing was really broken or injured. But back to my attending. So he was so amazing, you guys. Like, we really just sat and kicked it all morning and just talked. We were talking about medicine, humanism, real estate, what we want our future houses to look like, cars, like anything you could imagine talking about just to kill time, we talked about. But he made the environment super comfortable, you know. Like, be aware as a student though that you do not get too comfortable, right? Even if an attending is super chill, super cool, keep that professional boundary, right? Don't get caught up talking about stuff that is unprofessional or offending somebody by joking too much. You know, just read the room, still recognize that you are a student and that you should maintain your professionalism. But if an attending is chill, like, connect with them on a personal level, you know what I mean? Like, that just shows that you're an easy person to get along with and work with, which is most of what medicine is, right? Working with your team. So he was just super cool. He made it very low pressure for me, you know, to present patients and to learn. So I love experiences like that. And that's why I say don't get confused, right? Because that can make you think that, oh, I love emergency medicine. Not exactly. You know, I just really enjoyed my day today in fast track. I really enjoyed my attending, and that's that, right? So it's just been a really good time in fast track. I like it because ironically it's not fast at all. It's very slow paced. It's mostly just chilling, kind of waiting for the patients that you see to get whatever they need, their tests, their medications, whatever, and kind of turn over. But that turnover doesn't happen as fast as you would think. They're sometimes there for hours or even over shifts, you know, multiple shifts. So it's like, it's actually really slow paced and really chill. So unlike the normal ED, like the normal emergency room. So I had a really good day, you guys. I'm gonna run home right now, get changed, because I have back-to-back meetings today. So I am meeting with the chancellor of the health sciences schools, because I am a chancellor scholar. I have a full tuition scholarship to medical school called the Chancellor Scholarship. So I am meeting with him today, I guess to discuss that or discuss school and life, I'm not sure. And then I have back-to-back meetings this evening with my mentees. So busy day ahead of me, but I just wanted to say that it was an amazing day today, and I am back on shift tomorrow for the evening shift, 3 to 11 p.m. So I will catch up with you guys then. So one of the major responsibilities of an emergency room doctor is truly determining if a patient is sick or not sick. And obviously, everyone who comes to the emergency room is sick in some way, right? Whether truly, objectively, or physically, or they just feel sick. But anyway, the doctor's responsibility is truly figuring out, is this something that needs immediate medical attention at this moment because you are in true risk of potentially dying or having severe, medical emergency? Or are you stable enough that we can tend to other responsibilities or other patients who are truly sick, and come back, while you figure out more history or run the appropriate tests and are waiting on lab tests or something like that. So sick or stable. And then after that, it's a matter of stabilizing the sick patients for the time being, right? And really figuring out what is the most likely diagnosis of what's going on, sorting those patients by those appropriate diagnoses to the part of the hospital or sending them home, whichever is appropriate for their further care. A lot of times in the emergency room, you have to keep your options open, right? You can't narrow down into something that you might think is going on based on the history or what you see in the patient's chart. And you really have to make sure that you're thinking through all of the possible options of what can be happening or illnesses that this patient might be experiencing. One thing that emergency medicine doctors really are cautious of is making sure they cover all their bases so as not to miss anything that could potentially cause harm to the patient if missed. So therefore, in the emergency room, you see doctors cast a wide net, right? Running a lot of different lab work, getting a lot of imaging sometimes just to make sure nothing is missed. So most patients, when they come in, will at least get labs, checking their blood, their electrolytes, things like that, getting a chest x-ray to make sure nothing's in their lungs, everything looks okay with their heart, nothing really stands out, right? Patients who have complaints in their head, such as headaches, dizziness, anything wrong with their face, facial droop, concern for stroke, anything like that, will often get some sort of brain imaging as well. So a CT scan of their brain or their head and neck. Most patients at minimum will also get an EKG of their heart just to assess their rhythm and rate. Make sure nothing is going on immediately or acutely in their heart so that we don't miss a heart attack or some sort of arrhythmia that can cause sudden death. Another thing that I really enjoy that I've noticed in the emergency room is that they love their ultrasound, you guys. Ultrasound, we often think of it generally with like pregnancy, ultrasounding, babies in the stomach, make sure they're moving and growing adequately, right? But in the emergency room, ultrasound is actually extremely helpful. And sometimes we don't always appreciate the value of ultrasound. It gives you a quick glance at major organs and structures of the body to indicate any problems or acute, disease that could be going on. So ultrasounding the stomach to make sure that there's no free fluid or blood in the abdomen, ultrasounding the organs, the liver, the heart, the colon, your intestines, to make sure there's no masses, no bleeds, no acute illness that you can perceive on ultrasound that could lead you down a certain diagnosis path, right? So ultrasound is very utilized in the emergency room, and I appreciate that because as a student, we don't always get the exposure to ultrasound, right? To see how it's used, how do we learn how to use it in the clinical context of things, right? So you will see emergency medicine docs pull over an ultrasound and look at someone's heart to see if, is their heart pumping adequately? Even if they're not cardiologists or well-trained on ultrasound or cardiology, you can see on an ultrasound if a person's heart is functioning as normal. Is it pumping and squeezing strong enough, or is it super reduced or super stiff, or, you know, something looks wrong, right? So that you can consult cardiology and say, I did a bedside ultrasound and their ejection fraction looks pretty low. You know, I'm not an expert in this, but it's not pumping how it's supposed to pump, you know? I just had a case the other day in the emergency room where a woman lost vision in her right eye, totally painless, nothing was hurting her or anything. She just woke up and she couldn't see out of her right eye. It was completely black. So what did we do in the emergency room? We pulled over the ultrasound right next to her bed, right? And we literally ultrasounded her eye. And I had never seen that before, you guys. So we put some gel, told her close her eyes, put some gel on it, put the ultrasound probe on it, and looked in her eye to see, is her retina still attached, right? Is there any fluid or blood in her eye, behind her eye? What does her optic nerve look like? You know what I mean? So it gives you a quick image of things so that you can kind of sort out what's going on, rule in or rule out certain diagnoses, and then helps you kind of gear your care in a certain direction, right? So I love bedside ultrasound. I love how they use it in their emergency room to kind of help expedite and inform their diagnosis and care, and how it can really help you in your clinical judgment and practice of things. Woo, it is cold out here. Hey guys, welcome to emergency medicine shift number 3. So I'm still in my first week, you guys. Like I said, have front loaded a lot of my shifts in the first 2 weeks of this 4-week elective to give myself the final 2 weeks off, because that is going to be around match day, and I don't want to think about emergency medicine when I'm literally figuring out what I'm gonna do for the rest of my life, where I'm gonna be, where I'm moving to, like all of that comes with that. So yeah, already shift number 3. I only have to do 11 shifts of emergency medicine. So today I'm going to be in the main ER, you guys. So my first 2 shifts were in fast track, so kind of like urgent care type of stuff, like not super serious, kind of come and go, like nothing really needing to be seen emergently in the ED, the main ED. So now I'm going to be in the main ER, kind of seeing more serious things, more things that need and require immediate attention, and physicians and nurses kind of watching patients while they're there in the emergency room. So I'm gonna be on a team in the main ER, and yeah, I'm really excited. I'm working the 3 to 11 shift. This morning we had didactics, so Thursday morning are our didactic days, which basically means like lectures, classroom stuff, lecture stuff. So we were in lectures from 8 a.m. to 2 p.m. and now here I am at 3 p.m. going to my shift. So it's actually gonna be a really long day today. And luckily I am off tomorrow. Well, not off, but I'm doing the night shift tomorrow, so I have more of like the morning and day to sleep and recover. So let's go see what the ER has to offer us today, you guys. You guys, emergency medicine is just not for me. Like, it's for some of y'all, and it should be, because we need emergency med docs, but it's not for me. I think a part of being a good doctor is really knowing what you enjoy, right? And what's within your scope of not only what you like to do professionally, but your limitations and the kind of material that you don't like. And emergency medicine is just not for me. Super cool, but not for me. And this is my personal opinion, you guys. And like, you know, I'm only speaking from experience, but I feel like a lot of stuff is kind of just like checking off the boxes, right? So a patient comes in with chest pain and it's like, okay, we got to do a cardiac workup. And it's like, well, do you really need to do a cardiac workup? Like, is this chest pain that requires like an echo or cardiac imaging or a cardiology consult? Like, is all of that truly appropriate? So I just feel like sometimes it's like, okay, a patient comes in with something and like, these are the things we need to do, instead of looking at the individual and their risk factors as kind of individual cases, rather than kind of just like, oh, this is the diagnosis, so this is the checklist of items that we need to do. And I feel like that's been my experience in emergency medicine. That being said, I've seen some pretty cool stuff, you guys. So like I said, I'm in the main ED today, so kind of like the heavy hitting emergency medicine stuff. So the great thing about medical school, specifically the 3rd and 4th year, when you're seeing patients, the only years that I really like, is that
you will see sometimes, especially if you're at the same institution for all of your rotations, you will see a lot of patients again and again on different services. So I have a patient in the ED right now that I saw when I was on my medicine rotation almost a year and a half ago. It's crazy. So this young man has inflammatory bowel disease, so ulcerative colitis, and we saw him on medicine when he first kind of got the diagnosis. He had come in with bloody stools, blood in his poop, and like a lot of abdominal pain and discomfort. We were kind of working him up for inflammatory bowel disease back on the medicine team, right? And now he's coming back into the ED over a year later, and it's severe. It has gone so progressive, you guys. He now has like fistulas, and he's having like rectal problems and really, really severe disease over that time span, right? Of like the year and a half that I haven't seen him. It's cool to see a patient that I know and I'm familiar with and that I saw kind of in the beginning of his disease course. And now it's like, it's not cool to see his disease progress, but that I'm here for that, right? And it's like, that's the kind of beauty of medicine when you stay somewhere and you create kind of lasting patient relationships. And that's what I was really looking for in a specialty, a career in which I can see the same patients and have a patient roster that I see again and again and again. And internal medicine often gives you that. Obviously, that is not what's happening in this situation. I'm on a different rotation in a different specialty, but it was still the fact that like I saw a patient that I recognized and that I had seen and cared for before. That was super cool. I also had another patient, you guys, an older gentleman who got crushed by a forklift, legit got stuck between a forklift and a metal wall. And this man got crushed and he has spine fractures. All of his freaking back is like fractured up and bruised and swollen. And he was actually supposed to go to the trauma team, but they sent him to the emergency room because he didn't meet criteria for trauma. And now we're sending him back to trauma because the x-rays and CT scans show that he has all these spine fractures. And now that like is legit a trauma. So that was crazy. I have another guy, cancer all throughout his body, that lost vision in his right eye. So just seeing a crazy kind of mix of stuff, really grab bag emergency medicine. And that is the part that I do like about this rotation, is that you never know what you're going to get when you open the curtain, you know? But the part that really gets me and drives me crazy, and this is me personally, is that it's overstimulation. As I've said, it's overstimulation times 100. I'm like, whoa, someone's screaming, you know, like, whoa, this guy's having delusions and yelling about Russia and the Ukraine war and that he's going to be the savior of it all. It's just, it's a lot going on, and it's really hard to kind of desensitize and like blind and drown out all that noise to focus on whatever you're doing. And I just have no desire to do that or to try to master that or learn how to ignore patients and things like that. So no, thank you. But I am going to appreciate the next few weeks, and hopefully I have more really cool, interesting cases to tell you guys about and show you guys. But let me enjoy my coffee and then get back to the rest of this shift, which hopefully ends soon. All right, guys, so here I am in the student lounge in the hospital. So we have this nice room, couches and whatnot to kind of have a place to go when we're here working shifts. So this is where I store my stuff. It is 11:18 and I am just now leaving. So the shift changes, you know, after the 8-hour shift. So we changed over at 11, but it takes time for the doctors to switch over the patients, right? Because the doctor coming on knows nothing about the patients that are on the list. So the team turns the patients over to the next team, right? So we had to run through the like 20 patients on the list and kind of give like the brief story of, this is a 56-year-old woman who's coming here with bipolar 1 and manic episodes, you know, psych is waiting to see her, which is legit one of my patients. So yeah, so that's why I'm getting out of here a little bit later. Thankfully, I don't have to be back here until 11 p.m. tomorrow for the night shift. So I can kind of get some rest, sleep it off, recover, and come back again and work overnight. So
I'm gonna get my stuff and head home. Overall, it was a good shift. Like I said, EM is not for me, but I appreciate all the specialties in medicine. Like, I'll find something good I like in every specialty. It's just not something I want to do long term, you know. But I always suggest you guys come into medical school open-minded, because you're never gonna know what you like or dislike until you go in and really experience the rotation for what it is, you know, and see how you truly feel about it once you're exposed, instead of kind of coming in with biased or preconceived notions about what you're gonna like or not like, you know what I mean? You're kind of already dooming stuff before you even give it a chance. But all right, well, hopefully I don't have to come back here anytime soon. And this is why doctors and healthcare professionals have some of the most unhealthy habits, because of things like this. Like, coffee is not a meal, Julia. Like, haven't eaten anything, so I'm gonna go home, eat, and then literally shower and go to sleep. So I'll see you guys next time.
Hello friends, so it is Friday night in the emergency room. It is currently 1:30 a.m. I came in at 11. I'm in the main emergency room, back on the low side again with like the psychiatric patients. I've seen 2 patients already tonight. One guy is sick, it might be COVID. Another is a new diabetic, so definitely interesting cases already thus far. The shift is going fast, which I love, so let's keep it going. I have a break right now and all my patients are kind of tucked away. No one really needs anything at this moment. So my resident gave me the gold card. This is the money card, y'all. This has all the stuff on it, so you can use it in the cafeteria, at the vending machines and all that. So she was like, go get yourself a drink or whatever. So I'm about to run it up. No, I'm just kidding. I'm gonna get a coffee.
Yeah, let's try it out. Hopefully she didn't send me with no funds. Okay, am I doing it wrong? Oh, there we go, there we go, there we go. Yeah, buddy, I need that. Thank you, Anna.
In the middle of the night, sometimes you just take long scenic trips around the hospital, but no, I was just trying to find where ultrasound is, because one of my patients is bleeding vaginally, but she's pregnant, so we need to take her to ultrasound to see if she's miscarrying or if something's wrong. So they were like, Julia, go take the patient to ultrasound. I'm like, I don't even know where ultrasound is. That's one thing that the ED is, I'm seeing a lot of, is when the hospital is understaffed, and because of COVID and everything right now, the hospital is very understaffed. The staff in the ED have to do a lot, right? So a lot of the doctors are literally transporting their patients around and doing a lot of stuff just to get things moving quicker. So I will be taking my patient to ultrasound. All right, guys, I got dismissed a little bit early. It's 6:15. It did kind of get a little spicy, a little wild toward the end of the night. So we had 3 young girls come in. They had all taken edibles and they were high out of their minds, like freaking paranoid, hallucinating. It was actually quite hilarious. They were medically fine, so I can say that, but they were just screaming. It was a blast, you know? And then I got to do a laceration repair. A guy came in, he had fallen, he was drunk and had a kind of cut on his nose and busted his lip, the inside of his lip, kind of split that open. So we threw 2 stitches in his nose, 1 stitch in the inner lip, and I got to do those. So that was really exciting. It was like non-cosmetic, you know, like those aren't things that are gonna leave like super scars or anything like that. So the resident was like, go ahead and go for it, you know. So I got to practice on him. He totally agreed, complimented my work. So yeah, it's a good end to the shift. Today was actually pretty good. A little slow at times. The overnight shifts, like, they either go really, really fast or really, really slow. And they kind of were dragging. The first few hours were kind of dragging, but the last 1 or 2 were pretty quick. So I'm very excited to go home and go to sleep, you guys. I'm exhausted. Working overnight, I don't mind it, but you got to get on a good schedule, you know? And like with this rotation in medical school, you're doing shifts from 3 to 11, 7 to 3, 11 to 7 overnight. So there's no stability, there's no structure. So it makes it impossible to actually prepare or get enough sleep and stuff like that because your shift is constantly changing. Overall, it was a great shift though. My attending and my resident were amazing. So that definitely makes the shift go faster. It is freezing. Oh my gosh, you guys, look at that sunrise coming up in the background. Beautiful. I am going to sleep though because I am exhausted. So I will catch you guys later today when I wake up and am actually a human being again. So catch you on the flip side.
All right, friends. So excuse my appearance. It's been a rough morning. So I got home, you know, like 6:45 or so. Set my alarm for 9:30 because I needed to get my lashes done at 10. My alarm didn't go off because it was set for the next day, like set for tomorrow. You know, when you're setting an alarm, you usually set it for the next day. So since I was setting it this morning, it set itself for tomorrow. So it didn't go off. And I don't know, I just felt like in my spirit, I was getting a suspicious amount of sleep. So I woke up at like 10:15. I had a text message from my lash tech like, hey, are you still coming? I'm like, oh my God. So anyway, just got my lashes done, you guys. You can see they're nice and full. Looks good. So I'm running on like what, 3 hours of sleep. Got these done. Reason I had to get my lashes done is because I have a school event tonight. So one of the organizations I'm a part of, the Student National Medical Association, or SNMA, we are having our kind of annual gala, our annual dinner dance kind of formal event. So that is this evening. I'm also getting an award, you guys, there. So I was like, all right, let me get my lashes done, whatnot. So now I'm gonna go home, get something to eat because I'm starving. Try to squeeze in some more sleep because I'm still tired, you know, and I have this event tonight, but I work tomorrow morning, Sunday morning at 7 a.m. So it's not like I'm gonna have tonight really to get a lot of sleep. So I still wanna sleep from this morning. So get a little bit of sleep. Then I gotta do my hair, make myself presentable for this thing tonight. Write something down for a little 1 to 2 minute speech to accept my award. I don't know, I'm all over the place, you guys. So that is what my day is looking like today. I'll bring you guys along with me and let's get an award. Good morning, friends. So it is Sunday morning, 7 a.m, bright and early. You guys can see sun's coming up over in the background. It's crazy, you know, some shifts I'm getting home when the sun is coming up, some shifts I'm going in when the sun is coming up. That is the weird part of emergency medicine, is that it's shift based, you know. So it's nice because you're only working your 8-hour shift, whether it's the morning, the evening, or the overnight shift. You're only there for those 8 hours and you're only on a certain number of shifts per month, right? So a lot of EM physicians like the fact that it's shift work. They have a set number of shifts for a set number of hours every month, right? So whether that's 14 or 15 days a month, they're only working like half the month, right? So, and then they leave when they get to leave. Somebody comes in and relieves them. Whereas other specialties, it's kind of like you work until your work is done, right? Which could run you well over 8 hours, most of the time over 8 hours. But anyway, so we're headed in for another shift Sunday morning, 7 a.m. That overnight through Friday night into yesterday was pretty rough, you guys. You know, like as far as my sleep schedule, the thing about this rotation is that we're on all different types of shifts, right? Day shift, evening shifts, night shifts, and we don't really get the time for our sleep schedule to adjust, right? Because most physicians, they're on one kind of shift, right? They're on overnights, or they do day or evening shifts or whatever. So this rotation's all over the place so that we get exposure to kind of each types of shift and each type of like location in the hospital, fast track versus the main ED and stuff. So it's just not really conducive to getting on a regimen, on a schedule. But it's okay, only what, 7 shifts left, including today. So we're counting them down, you guys, we're counting them down. But yesterday was really cool. I had a dinner dance for an organization called SNMA. I got an award, you guys. I'll show you some pictures and some videos. It was really, really nice. I'm exhausted though because I didn't really get a lot of sleep yesterday, but
we move. So if you guys remember, I have been on the low side of the ED, so the low numbered beds, where the a lot of the psych patients are. Today I'm on the high side, so this includes trauma. So we might get to see some trauma cases or some like more serious kind of emergency medicine type stuff. Who knows? We'll see. But it's also Sunday morning, so what traumas are happening on Sunday morning? I don't know. Hey guys, so it is Monday afternoon, about 2:30. I'm getting ready to go in for my shift today. I forgot to touch base with you guys yesterday and let you know how my shift on the high side went, but it was pretty uneventful, which is why I didn't really have anything to report. It was cool working on the high side of the ED. So as I was saying, that includes traumas, like traumas that come into the emergency room. So that was really cool, but it was a Sunday morning and we didn't really see anything. It was a very uneventful day. So I just had a few patients with kind of like very common complaints, chest pain. I had a gentleman who has prostate cancer and he was bleeding a lot when he pooped. So that's very concerning for anemia and, you know, possible recurrent cancer and things like that. So that was kind of more of an urgent case for him. And then we did have a lady that came in with a suspected stroke. So that you see the, you know, the quick paced nature of emergency medicine when you have patients come in where it's time sensitive problems, right? So we had to rush her to the CT scanner to get a look at her brain to see if anything was acutely bleeding and whatnot. So that was kind of like a rush of excitement, but otherwise it was a very uneventful day, very slow. And yeah, so here we are. I'm working today the 3 to 11 shift. Today, guys, I'm actually on peds. So I'm on pediatric emergency medicine. So a completely different part of the hospital. Obviously, definitely different complaints, right? I just always think of it as like, oh, it's gonna be a bunch of snotty-nosed kids, but hopefully we see some interesting stuff. We'll see. But today is my 6th shift out of 11, so almost halfway there, you guys. Oh, I'm just ready to get through this week and bust it out. I know it's gonna be tiring, but you know, temporary pain for long-term gains, you know what I'm saying? So very excited for peds ED today. Hopefully it's chill, hopefully it's like goes by quickly and that we can get home and get some rest. I feel like I haven't really had a good night's rest since I began this rotation, so I need that. So luckily I have the day off tomorrow, so we'll be able to catch up on some sleep. But life of a medical student, we love it. We pray for this, we asked for this, and now we're here and all we do is complain. But anyway, let's pray for a good day, you guys. I'll catch up with you guys in a bit. Guess who got the gold card, baby? You guys, I low-key love pediatric emergency medicine. Like, I'm very shocked, but I'm enjoying my shift thoroughly and I'm very surprised by that. So I had one little boy, 3 years old, the cutest little thing, you guys. Like, cutest little thing. But we don't know what happened to him. He was playing around with his cousin or something like that, and his neck is hurting him. And his mom was like, I didn't see what happened, so I can't give you no story or whatever. But basically, anytime he would try to turn his neck to the left like this, he would cry, and he would like make it very apparent that it was hurting him. So, you know, it didn't look like it was fractured. It didn't look like anything super, super serious. I'm thinking that maybe he was playing around, jumping around or something, and maybe twisted his neck too hard, you know, and it's like a muscle strain, like kind of when you work out too much and the next day or 2 days or whatever, you're like very sore. So, or when you sleep on your neck wrong and then you have like a crook neck. So I think that's basically what was going on. We gave him some ibuprofen, sent him home, you know, watched him for a little while, sent him home. So that was that. I have another girl, 13 years old, came in with abdominal pain. It looks like she's kind of just has like a stomach bug. But then I go digging in her chart a little bit and I see that she's been at the hospital like 2 times every year over the past few years with a stomach bug. And it's like, girl, you ain't getting sick that much. You know what I mean? So like, what's really going on here? So then I go back in and I do like a thorough assessment of like, we call it the HEADS assessment, but it basically kind of assesses your home life, education, activities, drugs, sex, suicide, like the acronym HEADS. So I did a more thorough assessment of that. And here, like, I got this girl to really open up about some trauma that she's experienced. So she was sexually abused as a young girl with someone who's still in her family. And she's feeling overwhelmed. She's low-key even feeling suicidal. She cuts herself, something I didn't even see on my physical exam the first time around. So then I was like, whoa, like she has a forearm full of cuts that I never even observed when I did my first physical exam on her. So it was just like, I really got to the core of it, and I'm like, hold on, wait, is this abdominal pain or this stomach bug that she keeps getting month after month after month related somehow to this trauma? Is she, you know, trying to escape something? Is she coming to the hospital to give us a sign? You know, like these are the things you have to think through, and that can easily be missed if you just kind of chalk it up to, oh, just abdominal pain, she has a stomach bug, you know, let's give her some freaking like nausea medication or some water and let her go home. So that's that. Very interesting, sad, but very interesting case. And then I just saw a 9-year-old who is expressing that she wants to kill herself. So a lot of like psych patients, a lot of pediatric psych patients, which is like super interesting to me. And I've always liked psych in med school, you guys. Like I always said that I liked psych. I just couldn't see myself doing it forever. I didn't always feel like I could be impactful or super helpful. But it's still really interesting to see, and pediatric psych as well is like a whole different level. I don't think I have the emotional capacity for it. I'd end up fostering and adopting so many children. But still, it was like, it's made the day go really fast. So I only have like almost an hour and a half left, and I'm like, I love this shift. Look at that. So we're about to go get some snacks with the gold card and then go finish out this night strong. So who would have thought?
All right, guys, so I hope you enjoyed this Rotate With Me medical school vlog as I rotate through emergency medicine. This is a 4-week rotation, so this was only my first week, and I saw so much cool stuff, you guys. I am very fortunate to be doing this rotation, especially because I myself am not going into emergency medicine. I'm going into internal medicine. So this might be one of my only chances to see emergency medicine and really get this level of exposure to it, especially in like emergency pediatrics, right? Like being that I will be working with adults in my career, I won't probably ever see pediatrics again. So it's really cool to kind of get those exposures, those last times, really getting a student perspective of things before I begin my own career path and go down another way. So I will be back for another week of emergency medicine next week, and I will bring you guys along. So be sure you give this video a thumbs up if you enjoyed it. Be sure you're subscribed, hit that notification bell so you're tuned into all the latest content, and I will see you guys on the flip side. Stay safe, stay well. I love you, family. Catch you next time.